So a little bit more about this drug called Tagraxofusp or TAG. So the way this drug is constructed is it takes a diphtheria toxin and it binds it to this substance called IL-3 that binds to a cell surface marker, so a protein that exists on the surface of the cell called CD123. And the targeting of this protein, CD123, came from the realization that CD123 is very ubiquitously expressed on the surface of BPDCN cells. So we're harnessing that fact, that knowledge that this protein is almost always on the surface of these cells to say, well, why don't we target it and administer therapies directly into the cell using that protein binding site. So this drug tag binds to CD123. That the drug is then internalized by the cell and it releases the toxic diphtheria toxin that then causes damage to the cell's infrastructure to make proteins, and that leads to cell death. So it's a fairly elegant mechanism. It's an example of immunotherapies that we're using more and more in cancer treatment in general. So I don't want to belabor the details of the trials that led to the drug's approval, but I wanted to go over some of the data and which points to one, both the efficacy of this drug and why it's such an important tool in the treatment of BPDCN, but also why we need further trials and more therapies for these patients. So the initial publication of the first part of the trial was done in 2019. And then there was a follow-up of an expanded cohort of patients, so where more patients were enrolled, that was published in 2022. So I'm going to tell you a little bit more about the later publication and the overall results in those patients. So by the 2022 publication, there were 84 patients who were enrolled, and this trial enrolled patients who were newly diagnosed, so had not received therapy yet, as well as patients who were treated already. And so 65 patients were enrolled who were newly diagnosed and 19 who were treated prior. And overall, 57% of all of the patients achieved what we call a complete remission or complete clinical remission. And that's a really important endpoint because we want to get patients into a complete remission so that they can go and get a transplant. If you look at all of the patients who were treated on this trial, actually about 75% of them achieved any sort of response. So a complete remission requires a certain reduction in the amount of the abnormal cells in the bone marrow, a certain reduction in the lesions elsewhere. But if you look at any response, about 3/4 of patients achieved a response, which is really remarkable in this very, very challenging disease. And the responses occurred fairly quickly. So after only a little more than a month, patients were in this complete remission state. Importantly, about half of the patients who achieved a remission were able to go to a stem cell transplant. So once we get to this, percentage of a percentage of a percentage, we're only talking about 19 patients, but that's still 19 patients who are able to get this really important therapy that can cure the disease. One problem with treating BPDCN and with tagraxofusp is that although we do have some success and significant success in getting people into a remission, the duration of the response is not very long. So the median duration of response in this trial was just over 2 years. So patients had very frequent relapses after about 2 years. The survival of the patients on this trial was only 15.8 months. However, if you look at the patients who did go to transplant, their overall survival was over 3 years. So this points to the importance of going to a transplant once you're in a complete remission. So those patients who do have a good response to whatever therapy they get really do need to undergo a stem cell transplant from an unrelated or from a donor, not their own cells, but what we call an allogeneic stem cell transplant in order to have the best outcomes. Tagraxofusp does have toxicity that's very notable and important to recognize, and it's one of the reasons that this is really only given at specialized centers. The main toxicity, the most common toxicity, and the most frightening toxicity is this thing called capillary leak syndrome. And this occurs when the small blood vessels called capillaries end up kind of becoming leaky. So the cells that line these very small blood cells um, start to move away from each other, and the fluid portion of the blood, as well as some of the protein, starts to leak out. And this can be really, really dangerous because one, it can reduce patient's blood pressure because so much of the fluid volume from the blood vessels throughout your body is leaking out of those blood vessels, and patients can go into shock where their blood pressure drops, their heart is not able to pump appropriately, their kidneys start to fail, and that fluid that leaks out goes into places we don't want it. So it can cause pleural effusions and pulmonary edema. That's when you get fluid in places in the lungs that where you don't want it. Patients can be very, very sick, need to be intubated in the ICU on medications to sustain life. So this medication needs to be administered in the hospital when you first receive it because the risk of this capillary leak syndrome is really highest in the first cycle. In studies of this drug, this occurred in about half of patients. Most patients did not have a severe life-threatening form of capillary leak syndrome, but it requires immediate intervention when it does happen. There are ways that we try to prevent capillary leak syndrome. The first cycle has to be in the hospital, as I mentioned, and then subsequent cycles have to be in a clinic where they're trained to give this drug, and patients remain in the clinic for 4 hours after receiving the drug for monitoring. There are also blood test parameters and parameters for heart function in order to be eligible for this drug so that we are trying to make sure that patients have the functional reserve to get through a case of capillary leak if that happens. But it is notable that in the clinical trials of this drug, there were 4 fatal capillary leak syndrome reactions. So this is not something to be taken lightly. There are some other reactions that people should be aware of. So some people have hypersensitivity reactions, which is like an allergic reaction. Many patients, almost all of the patients had some liver test abnormalities, but those were reversible when the drug was stopped. And then there are some other reactions like nausea, fever, and weight gain. This one's probably related to the capillary leak syndrome as well. And these are things that we see and that we have to monitor in patients receiving this drug.